Hello, everyone. My name is Mary Lorino, and I'm an undergraduate student at Tulane University. And this past summer, I had the privilege of conducting research at the University of Chicago Pritzker School of Medicine in the neurology department under Dr. Caitlin Seibert and Dr. James Mastriani. My research is entitled Assessing Social Cognition Across Dementia Subtypes. So to begin, a bit of background on dementia. So dementia is characterized as a progressive decline in cognitive abilities that leads to functional dependence on a caregiver. Dementia has four main subtypes, and these include Alzheimer's disease, vascular dementia, Lewy body disease, and frontotemporal dementia. In figure 1 here, you can see a PET scan of a normal patient versus a PET scan for each dementia subtype. And the PET scans highlight which regions of the brain are most active in each subtype. And then a bit of background on social cognition. Social cognition is the ability to recognize how other people are feeling and make judgments based on those inferred thoughts in order to facilitate positive social interactions. And the overarching goal of this study is to measure how compromised social cognition is in each dementia subtype. Figure 2 here is called the network of the social brain, and it pinpoints the regions involved in social cognition. So connecting social cognition to frontotemporal dementia, or FTD. Clinical features of FTD include apathy, disinhibition, repetitive behaviors, and lack of empathy. These features align with reduced social cognition, which is what our study is trying to measure. FTD patients demonstrate reduced social cognition because they experience atrophy in their frontal and temporal lobes, and these are the regions of the brain most involved in social cognition. So because FTD patients have damage in these portions of the brain, they experience the highest degree of social cognition impairments. In figure 3 here, we can see an MRI of an FTD patient. And here we have an outline of the frontal lobe and then temporal lobe of where your brain should be in a healthy patient, but the reduced patient volume of this patient's brain due to their FTD diagnosis. And this reduced volume is most commonly seen in FTD patients. So while brain imaging is a useful tool in diagnosing dementia, it by itself can not usually distinguish FTD from other dementia subtypes because the imaging for FTD can look extremely similar to Alzheimer's disease. So this means that clinical features are vital for diagnosing FTD, and our social cognition battery has the potential to serve as another diagnostic tool. So to give an overview of the social cognition battery that we used in this study, it includes 3 tests, which are the interpersonal reactivity index, the mini social cognition and emotional assessment, or the mini C, and the awareness of social inference test, or the tacit S. So in figure 4 here, we can see a sample of the interpersonal reactivity index, which is a questionnaire that measures the emotional components of empathy. So here we have 2 questions that the IRI asks, and then the participant would rank how well that statement describes them on a scale from A to E. A meaning it does not describe them well at all, and E meaning it describes them very well. Next, the mini-C test contains 2 parts. Part 1 uses Ekman's 6 basic emotions to assess facial emotion identification ability. In figure 5 here, you can see Ekman's 6 basic emotions that are used in part 1 of the mini-C. So participants would be asked to name the emotion that these characters are portraying. Then part 2 uses faux pas tests to determine the participants' capacity to perform theory of mind tasks. An example of a faux pas story would be if 2 boys were talking badly about another student at the sinks in the restroom, and that student happened to be in the stall in the bathroom. Then when the student came out of the stall, the two boys who were talking badly about him quickly tried to change the subject because they didn't realize he was in there in the first place. A person with intact social cognition would recognize that something awkward and uncomfortable happened between the boys, but a person with reduced social cognition might think that the boys had a normal interaction. Next, the tacit S examination assesses participants' ability to detect emotion and sincerity of characters in videos. Part 1 assesses patients' ability to perceive emotions with videos rather than still images. So part 1 of the tacit S is really similar to part 1 of the mini-C, except for that the tacit S uses videos. And in figure 6, you can see an example of what the video might look like. And then in part 2 and 3, patients watch short video clips, which assesses their ability to distinguish sincerity from sarcasm. Now, when determining patient eligibility for this study, we used the Montreal Cognitive Assessment, or the MoCA test, which is a cognitive test widely used in clinics. And we decided that participants must score an 18 or higher on the MoCA, and controls must score in the normal range, which is a 26 or higher. And we determined these numbers to ensure that participants didn't have a degree of cognitive impairment high enough that they wouldn't be able to understand how to actually take the tests. To give an overview of the participants who have completed the battery thus far, I have two graphs that divide the patients by their diagnosis and by their demographic. So in figure 8, we have an overview of the participants who have completed the battery divided by their diagnosis. You can see that we've been able to assess participants who have been diagnosed with one of the 4 main subtypes of dementia, and we've also included patients with diagnosed primary psychiatric disorders. We've included primary psychiatric patients because FTD is often misdiagnosed as a psychiatric disorder, and we wanted to see how these patients compare to the FTD group. A total of 60 patients have undergone the social cognition battery. 18 of those patients have Alzheimer's, 11 patients have FTD, 9 have vascular dementia, 3 have Lewy body disease, 9 have a primary psychiatric disorder, and we've also been able to test 10 healthy controls. Next, figure 9 divides the patients by demographic. Out of the 60 patients, 43 identify as white, only 12 identify as Black or African American, 1 identified as Hispanic or Latino, and 4 identified as Asian or Indian. We can see here that the majority of our patients identify as white, so it's evident that we need to focus on recruiting and maintaining patients from non-Caucasian backgrounds so that we can equally assess social cognition among different races and ethnicities. We also want to ensure that social cognition is not compromised uniquely in one demographic versus another. Next, to go over some preliminary results of the study. After scoring each patient's battery, I averaged the results for each patient group for each of the tests. Figure 10 here depicts the average score of each test for each patient diagnosis. This graph compares the patient groups in different colors rather than comparing each test to one another. The average score for the FTD group is given in red, and it's compared to the other patient diagnoses shown in the grayscale. And it's imperative that we highlight the FTD results, as our original hypothesis suggested that FTD patients would score the lowest on the battery due to their reduced social cognition. So here I have a breakdown of the numeric averages of the battery with some standard deviations. And I won't go over all of those numbers, but just to go over some important conclusions, you can see that in the red, the FTD subgroup consistently scored lower on all the assessments in the battery. So this means that FTD patients do have reduced social cognition, which includes degrees of empathy, emotion recognition, and interpretation of social situations. So these results demonstrate that our social cognition battery has the potential to serve as a diagnostic tool, and these results demonstrate the potential for bedside social cognition assessments for early diagnosis of FTD. And then some future works. We hope to include at least 25 patients per diagnosis in the study, in addition to 25 healthy controls. This will ensure that we have a wide range of robust data for this study. Like I mentioned before, we also want to ensure that we recruit patients from a variety of cultural backgrounds so that we can equally assess social cognition among many different demographics. And then lastly, I would really like to compare the baseline neuropsychological testing results to volumetric MRI imaging. A volumetric MRI would show us the relative brain size of each brain component in a patient, and we would be able to compare that imaging to the battery to see if atrophy in one brain region is corresponded to poor results on a certain part of the battery. And this would allow us to really connect the biomarker to the behavioral testing that we've already done. And I think that would be really interesting. Lastly, here are just some of my references that I used to learn about this study and learn about dementia and social cognition. And then lastly, I would just like to say thank you to my mentors, Dr. Seibert, Dr. Mastriani, Dr. Prabhakaran. at the University of Chicago in the neurology department. I would also like to thank Dr. Flores for her mentorship and leadership of the Leadership Alliance program that I took part in this summer. I would also like to thank the Dendrites program for funding this research and experience that I had a great time participating in this summer. Thank you all for listening.